Good evening, everybody. Thank you for joining us for session 8 of the Aging and Elderly series with the Link family. It's a pleasure to have us all here. Thank you for joining us early. We still have some time to invite other people to this session because we are just starting the meeting. And it's going to be live on YouTube. The YouTube handle is Temitope Praising Child. Dr. Anjorin, if you don't mind just putting that YouTube link on there for those that are unable to join the Zoom or have any issues joining the Zoom. Bit of housekeeping, please keep yourself muted throughout the meeting till we get to the question and answer session. Feel free to type in the chat and be lively. And if you're on YouTube, feel free to type your questions on the YouTube. I'll be checking that as well towards the end of the meeting. And so without much ado, I'm happy to let us know that our speaker for tonight, this evening, well, I know we're joining from different places. Our speaker for this evening is with us, and he's none other than Professor Olufunmilade Omisanjo, and he's a professor of surgery and a consultant urologist. And I'll just be letting you know his bio, which he told me was a short bio, but it's not a short bio at all. But I'll be reading it very shortly. Okay. So Professor Olufunmilade Akinfolari Omisanjo graduated from the University of Ibadan in 1998. That's my alma mater, I'm glad to tell you. He had his specialist training in urological surgery in UCH Ibadan and fellowship experience in Germany, having been the recipient of a German academic exchange program scholarship in 2004. He had additional clinical exposure in medical centers across the US, the UK, Brazil, and Mumbai, India. He's a fellow of the West African College of Surgeons and an international fellow of the American College of Surgeons. He also holds a master's degree with distinction in organ transplantation from the University of Liverpool, United Kingdom. He joined the Lagos State University College of Medicine as a lecturer and honorary consultant urologist about 19 years ago. He has a wide range of research interest in uro-oncology and male reproductive and sexual health, and has authored over 80 articles in peer-reviewed journals. Aside his clinical and research duties, Professor Omisanjo has been involved in capacity building in several tertiary hospitals across the different geopolitical zones in Nigeria, with particular emphasis on developing surgical skills and expertise in the management of early prostate cancer. He is a member of several professional bodies, both in Nigeria and abroad, including Europe and America. He serves as an examiner in the membership examination of the West African College of Surgery. He is a professor of surgery with the Lagos State University College of Medicine and an honorary consultant urologist and transplant surgeon with the Lagos State University Teaching Hospital, LASU, Ikeja, Lagos. He's also the immediate past head of the Department of Surgery in the same institution. He's happily married with children. Join me as I welcome Professor Olufunmilade Omisanjo. Over to you, sir. Yes, over to you, sir.
Good evening, friends. Thank you very much for having me on board to share my thoughts on the topic aging concerning the urinary concerning the aging male. I hope you can hear me clearly.
Yes, we can hear you, sir.
All right. So yeah, I'm very aware of any network issues. So if at any time you can hear me, please let me know. So once again, good evening for having me on board. Thank you very much. I appreciate it. And I'll spend the next 30 minutes, 45 minutes, we said, sharing my thoughts with you on genitourinary concerns in the aging male. Like we've been told by the previous speakers, aging will say, yeah, when people cross 60, 65 years, but like Dr. Shriambo told us last week, if you're looking at maybe community, a population like Nigeria, where the life expectancy is much less, you can technically even say people qualify to be described as aging once they cross 50. For the purpose of today's discussion, I'll be looking at changes, genitourinary changes that occur in men as they cross the age of 50, 60. As people get older, there are changes that we expect to occur in the urinary tract. And the urinary tract, if you recall, we'll start with the kidneys. Everybody has two kidneys, and then there's a bladder down there, and then there are these two tiny tubes that carry urine from the kidneys down to the bladder that we call the ureters, and then there's another tube that carries urine from the bladder out that we call the urethra. So the anatomy is similar in men and women up to the bladder. Beyond the bladder, then you have that difference. And the tube that carries urine from the bladder out is a much shorter tube in women compared to the relatively longer tube that runs through the male organ in men. And at the base of the bladder, wrapping itself around the urethra in men is what is called the prostate, which is the big thing we will still talk about sometime later on today. So from the kidneys down, so my beat is to talk about the genitourinary changes in men, and I'll just concentrate on that. So the changes that occur will occur involving every one of these organs as people get older. Again, anything from the age of 50. So in the kidneys, for example, we expect that as people get older, the nephrons, which are the units that the functional units in the kidney, they begin to reduce. Actually, those changes may occur as early as, yeah, you lost me.
No, go ahead,
I
sir.
don't know if you can still hear me. All right, so thank you.
You can go on, sir.
Okay, so all right. So some of those changes in the kidney may occur even as early as in their 40s, when people are in their 40s. As people get older, the number of functional units in the kidneys will reduce, and so there can be a gradual reduction in the size of the kidney and in the ability of the kidney to carry out its function of concentrating urine, conserving water, and all that. I'll come back to that later. The ureters don't have too many. That may actually be an advantage to a surgeon, because if you're doing things like ureteroscopy, laser lithotripsy, it makes access to the ureter a lot easier than when you have a much younger person. But when we then get to the bladder, what happens as men get older is that one, the bladder muscles become weaker. And the importance of that is the ability for the bladder to contract and push out urine may reduce. And so men may then be predisposed to retaining urine, all right, from loss of bladder muscles, because the bladder muscles may become, flaccid. But what can also happen in some men is that the bladder muscles also become less compliant. What do I mean by that? Normally, the first time we all feel the urge to pee is not the time we have to rush to the restroom. And that is because the way the bladder muscles are is so that when urine accumulates in the bladder muscles can stretch out and collect some more urine, stretch out some more, collect some more urine until we get to a critical point where when the bladder muscles can no longer stretch to accommodate more urine. So that ability of the bladder to stretch to accommodate urine is what we call compliance. The bladder compliance gets less as people get older. The import of this is sometimes in some men, what aging, the way the aging changes reflect in their bladder is that they are less able to retain urine. And so with very little urine in the bladder, the person has to just empty the bladder, because bladder muscles will then contract. And not only will the bladder muscles contract, they sometimes contract so strongly that the person feels a very urgent need to go to pee that they cannot delay. And that can be quite disturbing for some men. Some men actually go on to wet themselves. So sometimes the changes in the bladder will be from loss of bladder compliance. Sometimes it is from a reduction in muscle. Of course, with the prostate, the major thing that will cause the prostate as men get
I don't eat
older
much.
is
I
that the
eat
prostate
like this.
gets
Like
bigger.
if it's canteen, like maybe 300
I can
naira,
continue.
maybe like two. So as in something like this, it can't be more than a head.
What are you
So as
doing?
in, so
Okay.
Apologies, sir.
No. All right. No, that's fine. It's okay. So, all right. So, as people get older, as men get older, the prostate also gets bigger. And when the prostate enlarges, it does that in one of two ways. There is an enlargement we call BPH, benign prostatic hyperplasia, just the big medical term for an enlarged prostate that is not cancerous. But the other big type of prostate enlargement is what we call prostate cancer. We'll come to that later. The other thing that happens in the genitourinary tract is that men begin to notice a reduction in the size of the external genitalia. So, for example, men may notice a reduction in their testicular volume. Not only is there a reduction in testicular volume, if men were to check their seminal fluid check their sperm counts, they will also notice the sperm counts are dropping. Of course, that is an invariable part of aging. In fact, that may occur as early as in the 30s for men. So the best time for sperm counts are usually like late teens, early 20s, that sort of thing. When men cross 35, they're about 40, definitely the sperm count is expected to drop, and it becomes even, the drop becomes even more pronounced as people then cross 50. Of course, we know there is no age a man gets to that we can say a man cannot absolutely not father a child. People are able to father children sometimes into their 80s. So of course, we always have all these other ethical debates as to, when men have to, when just men, when couples wait till very late to father children, to start parenting and all that, but that's not what we're talking about today. So the external genitalia may be noticed to be shrinking. At that time, testicular size may reduce. The penile length too may also reduce and all that. Most men will probably not will not worry too much about the penile sizes at that age. What may bother them more is more of the function when men begin to have erectile dysfunction. So in terms of how these things translate to symptoms and diseases in men. So, what are you looking at? What do these changes cause? The 4 or 5 most prominent changes or symptoms that people will then have are: one, what we call nocturia, which is waking up to pee; two, incontinence; three, men have what we call lower urinary tract symptoms; four, men can have erectile dysfunction and ejaculatory problems; and then five, we talk about problems with the prostate. And I'll take each one of those. So nocturia means waking up to pee at night. Now, most authorities will say, well, it's understandable if an aging man pees maybe once. He wakes up to pee once. But by the time you get into 2, 3 times, most people begin to worry. Of course, there are people who will argue that even if a man wakes up to pee at once, you should look at it. And the significance of nocturia is not just the fact that it can affect the quality of sleep of an aging man. It can also impact on the management of other diseases. What do I mean by that? Of course, somebody who doesn't have good quality sleep is likely to struggle with the control of his blood pressure. Physicians will tell you that. One of the things people will tell you if you're managing high blood pressure is rest well, get a good sleep. So if somebody is having to wake up 3, 4, 5 times, as the case may be, to pee, that impacts on his quality of sleep. It can impact on the control of other medical conditions that he has, especially like control of blood pressure. But most importantly, waking up to pee in the elderly can predispose them to falls. And so, because the man wakes up, is not fully awake to make it to the restroom, people trip and fall. So, nocturia is a known cause of domestic accident in the elderly. And that is why it's an important thing to talk about. Like I said, some of the changes that occur in the bladder can predispose a man to having nocturia. I did talk about the reduction in bladder compliance that occurs as people get older. The bladder can just not hold as much urine as it used to be able to hold. Very little urine in the bladder wants to push it out. And so the person has to go to empty frequently. What is more, for people who have reduction in the contraction of the blood, in the ability of the bladder to empty itself of urine, what happens is over time, the patient can begin to accumulate urine in that bladder so that the effective bladder volume reduces. Each time the patient goes to pee, it's just that instead of emptying his bladder, it's just as if it's just decanting part of the urine in his bladder and he's carrying around some dead weight all the time. So the amount of bladder space that is left before the bladder fills up before the next pee is just very little. And so these are some of the things that can happen. So sometimes the nocturia is purely from those aging changes that occur in the bladder. But sometimes it could be due to the habit of the patient. So there are people who well into their old age still eat late in the night. Sometimes people still drink late into the night. These are things we discourage as people get older. Though for some elderly people, it's a conundrum of some sort. So doctors will generally, the healthcare practitioners will advise elderly people to take a lot of water. They need to stay hydrated because there are other problems that can come from dehydration and all that. But the elderly need to know that when we say stay hydrated, you have to do much of that water intake earlier on in the day. So most of it has to be in the morning, afternoon, earlier on in the evening. So typically, what we advise the agent to do is that once it's 2-3 hours to when it's your bedtime, you cut out it, whatever that is, whether it is, if you live in a place where they do English breakfast tea, afternoon tea, evening tea, and all that, whatever I need tea you want to do 6:37, you want to do it early enough. And so restricting the amount of nighttime fluid intake, whether it's water, whether it's tea or juice, that can help in that regard. So sometimes it's the lifestyle that somebody has adopted. Of course, this can be quite tricky because again, sometimes these are lifelong habits that people have had that you're not, asking them to change. I recently had a gentleman who, we were dealing with his nocturia, and one of the triggers for him that I found out was he had a habit of always going to bed with a glass of wine. It was something he always did. And when you treat elderly people, there is a little bit of, I don't know, do you call it psychological? They can have a way of almost blackmailing you. I recall the old man telling me that, look, doctor, you're asking me to stop a habit that, that he claimed he's had even before I was born. When you're treating 70, 80-year-old patients, the way they can, and they're close to you, some of the things they can tell you. Of course, I then respectfully just told him, well, sir, your body now is not what it was when I was born. So sometimes you just need to let people know, even when these are lifelong habits, that they need to start changing that. So it is good to be for the elderly to be hydrated, but nighttime fluid intake is something we usually want to restrict. So sometimes something as simple as that is what the patient needs to stop the nocturia. Okay, sometimes people have to take pills at night. We always tell them you don't have to, start gulping water to take your pills. Just do that with sips of water, and but sometimes it is actually the medication, the physician has prescribed that is causing the nocturia. Some people who are on diuretics for high blood pressure and they have to take those things at night. So that raises the need for a discussion with your GP, your cardiologist, or whoever it is. You just have to. Sometimes the problem is with the doctor because the doctor just does not want to change. If the nocturia is becoming bothersome, you need to pick your doctor up on that. They have to come up with another kind of regimen of medication that will allow the patient to have a very good sleep. It's not every time that somebody has nocturia that it is from a necessarily medical condition like that. Sometimes some people have nocturia because they snore. Snoring is one of the triggers for the secretion of what we call atrial natriuretic peptide. What that does, it's like a water pill too. It's a substance the body produces when people snore, and that can make the kidneys produce more urine, and then the person is waking up frequently to pee. Sometimes too, it is redistribution of fluids within the body of the elderly. So we know there are some elderly people, when they sit around and all that, they have a lot of, we know sometimes elderly people just have leg swelling, and that's because of, blood, I mean, not blood, fluid oozing out into the interstitial space and all that. So when they then lie down, there is always redistribution of this fluid back into the intravascular compartment. And so the blood flow to the kidney increases, and with increase in blood flow to the kidney, you expect an increase in the amount of urine that is produced. It's the same thing that happens in elderly people who may have some cardiac problems, who may have some heart problems, some problems with their kidneys. It's when they lie down that the fluid that has been stuck in some other parts then find its way into the intravascular compartment. That increases the perfusion to the kidney, blood flow to the kidney, and then they begin to make urine. So sometimes nocturia may be an indicator or some other underlying condition or some other medical problem that the person has. So usually when we want to evaluate people, yes, you try to find out. You sit down with the person. Is this just something that is strictly aging? Is it something that is from lifestyle? Is it from his medication? Or is it actually a pointer to something more serious going on, like any of these other medical conditions I've talked about? Or is it even from an enlargement of the prostate? I'll come back to that later. So what do we do if people have nocturia? One, you try to avoid the triggers. If it's from a medication, you speak with your doctor about changing the timing of that medication. If it's lifestyle of nighttime, late intake of fluid or food, we want to restrict that. Okay, and sometimes you for whatever medical condition you identify, whether it's diabetes or heart failure, we treat appropriately. I'll still come back to the role BP, prostate enlargement plays in this. Quickly to incontinence. Sometimes as people get older, they struggle to control urine. Urinary incontinence just means urine leak. So we should know when we want to pee when we want to, and stop pee when we want to. If somebody just notices that urine comes out when he doesn't want the urine to come out, we say that is incontinence. So that inability to control, urine leak is just incontinence is just urine leak. That's a simple way to understand it. And there are different types. There is what we call urge incontinence. There is stress incontinence. There is overflow incontinence. Urge incontinence is, like I mentioned earlier, somebody feels a sudden urge to pee that he cannot delay. Some people will then go on to wet themselves. So that's what we call urge incontinence. Sometimes the incontinence is a leak that occurs when something happens to increase the intra-abdominal pressure. Like the person has a good laugh, he lifts an heavy object, he coughs, he sneezes, that sort of thing. That I must say is more common in women, but it can also occur in men, especially men who have had some form of pelvic surgery and some men with prostate issues. Sometimes it is what is called an overflow incontinence. In men who have long-standing prostate enlargement, in which they are not aware of, gradually some men can be retaining urine without knowing. It gets to a point the bladder can get so distended that the urine coming down from the kidney has no other place to go other than to flow out through the urethra. And the man just sits and he notices that urine is just coming out without him knowing. So whether it is urge, stress, or overflow incontinence, it is important to know that usually these ones will be due to some form of bladder-led obstruction, commonly in the aging male, the prostate issue. But sometimes it is just purely an overactive bladder. But it is important to pick these symptoms and to deal with them, because we know that it's been documented that urinary incontinence is one of the triggers for social isolation in the elderly. And so there is a party. We're inviting grandpa to come. He just doesn't want to come, and he doesn't say. The reason is the man does not want to go and embarrass anybody, because nobody wants to be in a party. He knows he's going to be there for 4 hours. He needs to, he has to, probably use the restroom 2-3 times in an hour to avoid leaking urine, and nobody wants to be an embarrassment. And sometimes he doesn't even know when to drink. So when we miss it, we just find out that sometimes it limits the amount of social integration that the elderly can have Sometimes so. It's one of the causes for it causes social disconnect and social isolation in some of these people. Again, for people who retain urine that we do not know, it can be a risk factor for urinary tract infection and sepsis in the elderly. And I'm sure when we had the session on delirium, somebody will have mentioned to you urinary tract infections are a common cause of fever and delirium in the elderly, people acting confused, and all that. So while we can have triggers for some of these things, like sometimes it's alcohol intake, it's a particular spicy food that somebody is taking, sometimes it's exposure to caffeine, and of course, once you avoid those things, people get better. But we need to know that sometimes there is an underlying disease condition, and the number one thing you want to rule out in the elderly will always be an enlarged prostate. So going forward from nocturia, nighttime, waking up to pee severally, to incontinence, I'll then talk about lower urinary tract symptoms, which are those urinary symptoms that people have once they have some bit of obstruction to the flow of urine. Again, in the elderly, in 90% of the over 90% of the cases in the aging male, it will most of the time be due to an enlarged prostate. So these symptoms, we broadly put them into two groups, what we call the voiding symptoms that have to do with emptying the bladder, and then we call the other group of symptoms storage symptoms, which are symptoms that have to do with the bladder storing urine. So the voiding symptoms commonly that lower urinary tract symptoms that the elderly can have include things like hesitancy. The person may just notice that when he wants to pee, he has to wait. That delay in initiating urination is what we call hesitancy. Sometimes people will complain of posturing. The gentleman just notices that the flow of urine is not as strong as it used to be. Sometimes it's what we call stop and start intermittency, intermittency. What I mean by that is normally if you see young lads pee, urine just goes like that, till the end. But somebody is peeing and then he goes into the restroom and what you hear is more like foo, 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 like our internet can do sometimes. That kind of breaking transmission, breaking flow of urine, that intermittency, can be a pointer to possible, obstruction that the person may have. Sometimes what you may notice is the person has what they call feeling of incomplete bladder emptying. He pees, but he still feels as though he still has some urine, left in there. All right. And then sometimes it is that after peeing, urine continues to drop, what we call terminal dribbling. Okay, so some of these are some of the voiding symptoms that the elderly can have, which can be pointers to some of these changes we've talked about in the bladder, but more importantly, from an obstruction, from an enlarged prostate that nobody may have, been aware of up until that time. The storage symptoms, I've referred to some of them: frequent urination, having to pee less than 2 hours apart, nocturia, waking up in the night to pee, or that difficulty in delaying urination, what we call urgency. So when we then don't pick any of these things early, sometimes the very first time an elderly male will know that he has an issue with his prostate is when he goes into retention, and then we need to then pass a catheter to relieve that. Of course, once we notice any of these symptoms, while they can be due to, like I said, the lifestyle of the person, may be due to just straightforward bladder changes that occur with aging, they may also be indicative of more serious conditions on the line. And that is why the minimum we can always do would be to check out the person's prostate by doing an ultrasound of this prostate, then a simple blood test we call a PSA, and getting the doctor to do a digital rectal examination. And once an enlarged prostate is diagnosed, it's something that is easily treatable. Sometimes we just lifestyle modification without needing medications, but we have an array of medications, alpha blockers, for example, that relax the bladder neck and let the person empty his urine very well. We have 5-alpha reductase inhibitors that can help to shrink the prostate over time. Sometimes we combine them. If what the patient has is more of the storage symptoms, we may have to give anticholinergic to relieve, to relax the bladder, to be able to allow the patient more time, a longer interval in between voids. When people can't tolerate maybe anticholinergics because of some of the side effects like constipation, blurring of vision, and dryness of the mouth, things like that, you can give them what we call B3 agonists like mirabegron, vibegron, and all that. So you have a host of medical options to treat these things satisfactorily. And for people who need surgery, we have surgeries that can be done. Yes, the regular open surgeries are there, but nowadays you have so many endoscopic options, kiosk options that are available they are now pretty commonplace even in Nigeria, that it can be done safely. And so prostate enlargement is no longer what somebody should be scared of. So I'll quickly talk about erectile dysfunction. Pastor Sugomi, I can talk about erectile dysfunction before the break, or we have to do the break now?
No, you can do that and then go to the break.
All right, so I'll talk about erectile dysfunction and ejaculatory issues. Part of what we said can occur with aging is a reduction in the size of the testes, the phallus, and all that. But of course, as long as most men have erection, they will not really bother. Because whatever reduction in size that people have is usually not bad enough for them to allow for them to be able to have satisfactory sexual intercourse. However, we know that statistics have shown that, again, 40, 50 is the cutoff. If you look at the Massachusetts aging study that was done, once men cross 50, at least 40% of them will report some degree of erectile dysfunction or the other. Sometimes that is age related, sometimes it is due to other things. And one of the simple medical students, like back in the days, we used to like acronyms and all that. One of these simple ways to remember the various causes of erectile dysfunction would be if you use that thing, we say impotence. And what are the common causes? For example, for inflammation, if somebody has something like prostatitis, M for mechanical problems. For example, there is something we call Peyronie's disease. A man can have a situation because of repeated injury to the penis. He can have some scarring in a part of the penis that then precludes a very good erection. So sometimes it's a psychological problem within the marriage or within the man's workspace, and all that will lead to erectile dysfunction. Though that is is a two-way thing. We do know psychological issues can lead to erectile dysfunction. Erectile dysfunction can also lead to psychological issues, which is why we should always talk about these things. It's not, when you deal with the elderly, it's amazing the kind of things they have to cope with. We don't listen to them. Sometimes we trivialize their worries, and sometimes we choose for them. What do I mean by that? I have had patients come to me, 60, 70-year-old, who have erectile dysfunction. Sometimes erectile dysfunction will start from what the doctor prescribed, all right? And then, the man goes back to his doctor and says, he noticed erectile dysfunction when he started, and the man is like, in this part of the world, they're like, Baba, you want to die, that sort of thing, as in is 70, and the doctor, in his own wisdom, prioritizes the patient's treatment for him because, in his own wisdom, treating the high blood pressure is more important than the man's erection. You are not in any way. No doctor has that right. If the patient has developed erectile dysfunction and has come back to complain about it, I think as medical patients, the oldest patient I've treated for erectile dysfunction, I think is an 82, 83-year-old man. And I know he's just 1 or 2 years short of 85. And he came back, he was quite happy. So no two 82-year-olds are the same. There are people who at 60-year-olds will live with erectile dysfunction. It is not a problem for them. Some other people, it is a big deal, even at age 80. So we need to listen more to the elderly, and if anything, make it easier for them, make it make it a lot easier for them to discuss these things with us or with the professionals that are ready to listen to them. Because I do know sometimes, he was talking about psychological erectile dysfunction that took me there. I have had patients that, because when erectile dysfunction is due to a medical problem, doctors were able to deal with that better. But sometimes when you have some psychological issues, some of them are deep issues that, as a urologist, as a with gynecologists, wherever you are treating erectile dysfunction, you can't deal with it as a couple. I've had situations that patients came to me telling stories that, you know, sometimes patients can be very graphic. You just say, you know what, what you need is a sex therapist, and when we can't get a sex therapist, I just get one or two of our clinical psychologists and a psychiatrist who are able to deal with some of the psychological issues there. But the important thing is that we should listen and make it easy for elderly people to talk about this. The O is for occlusive diseases, that are diseases like hypertension, diabetes, that can cause blockage of the blood flow to the penis and then cause erectile dysfunction. We say you know, and then T is for trauma. For example, when people have injury to the pelvis or to the penis, that can cause erectile dysfunction. E for extra, things like, you know, when people have had surgeries in the pelvic area that might have been damage to the nerves that subserve the function of erection, and people can have erectile dysfunction from that. That can be neurogenic causes, like when people have spine issues, whether it's a spine trauma, whether it is, you know, spine cord tumor and all that. Sometimes C we say for chemical, and that is mainly when the doctors are at fault. They prescribe medications that, yes, treat the primary condition that's taken the doctor, the patient to the doctor, but now it's at a cost that is a little bit disturbing to the patient, the cost being erectile dysfunction. And then E, we say for endocrine diseases like diabetes. These are some of the causes of erectile dysfunction. But the most important take home for that bit, like I said, is we need to make it easy for elderly people to talk about erection. Because if you come from scanning through the audience, I think most of us come from a conservative Christian background where people just feel there are some things that are more important than some others. The important thing is that you do not decide for the 70 or 80-year-old man whether he feels his erection is important or not. We should make it easy. And what is more, psychiatrists will tell you a man's sexual health is an important part of his mental health. And I jokingly tell people, if you have a middle-aged man, who is your boss at work, and is just unduly, moody or unduly irritable, sometimes you need to check out his erection. And it is easy to do that. If you Google IIEF, International Index for Erectile Function, there's a questionnaire there that you can administer to anybody. It can be self-administered, and you see what your scores are. The ideal score will be 20 to 25. Anything less than a score of 22, out of the ideal score will be between 22 and 25. Any score less than 22, out of a total score of 25 will mean that gentleman has some bit of erectile dysfunction, which again can be treated by different options. We have pills, we have injections, we have vacuum device, that is implant. I tell people, even people with spinal cord injury, you can treat the erectile dysfunction. And usually when I give talks on erectile dysfunction, what I tell men is, every man an erection guaranteed. No matter the age of the man, no matter what is causing the erectile dysfunction, you can always treat erectile dysfunction. So I think I'll take the break now, and then when we come back, I'll just round up with the big one, the prostate. Thank you very much, Pastor Sukomi.
Wow. President Child, should I just go on with the introduction, or you have something to say?
Yes, please go on right now. Yeah.
Okay. All right. That is awesome. And please, I know that some of us, we have questions. Please start noting your questions. And when we get to that point, we will take them. Please, let's appreciate Professor Omisanjo for this awesome time we just had with him. And just so we can have a little time of respite. And just to digest. We will not have even digested everything before it comes back again. But just a time for us to marinate on the things he had spoken about already. I would want to just give us an introduction to this group, the Link family. And this is important, so you will not be wondering, what is this about? What is this group about? Why are we doing this? So the Link family is, just as the name is to create a link. Is to create a link. You know, they will say that the weakest point of a group is that point where there is, or what makes a group strong rather is their weakest point. Where how weak or strong that is what determines their strength. But for us as human beings, we should know that God didn't create us to be in isolation. So it creates us to need one another. And sometimes the difference between a successful life and a life that is not as successful may just be the link. It just be the link that they are two. So I would say that this family is open. The link family is opened to every individual from ages 16 and above. And this is focused primarily on healing and building healthy relationship. And it help individuals, which may be couples, parents, singles, to have an experience of a whole life experience, actually, catering to the total man, the body, the soul, and the spirit. And it's also open to people from all tribes, all backgrounds, nation, race, religion. Yes, our principle, our guiding principle would be God's word, but anybody can come. Okay, anybody can come, and like we have in the past, we have had several meetings. Usually, we meet on Fridays, every Friday, uh, but because of this series we have started, this is the 8th episode of this aging series, which is holding on Saturdays. So we are not having our Friday meetings except for the last Friday of every month where we meet to pray. But on a good, normally, what we do normally is we just do alternate Fridays where we do meet to pray, meet to pray. So we either pray or we discuss certain important people in the Bible, taking nuggets from their lives. And sometimes we do what we call mystery guest, where we would have an individual among us or somebody that is maybe known or not known to everybody that will come to share with us some of their life journey in one area or another. It could be parenting, it could be relationship, it could be anything. And we do that also from time to time. This group, actually, the Link family, has transitioned from being find the link to the link, because we know the link is found. And it was founded in 2020 by our dear sister and friend, Dr. Temitope Ayedun, the present child, and she's been the convener. And apart from the meetings we have on Zoom, we also have all our meetings, including the one that is going on right now, live on YouTube. So you can also be part of it. And after the meetings, if you miss a particular meeting, or the ones we have even had in the past, you can relive that experience on YouTube. Just go to the Temitope Present Child as the handle on YouTube, and you will find those there. I can tell you for a fact that this has been a tremendous blessing to me, as a member of the team of the group, and as one who has been blessed tremendously here. So if you really want to be a part of this, just so you are attuned or you are in touch with what is going on, you can join the YouTube, the WhatsApp group. And somebody will be dropping that in the, yes, you can see it, Sister Olanike has dropped that. You can click on that to be part of the WhatsApp group so that you can get day to day, because even on daily basis we have conversation going on around topics, issues of life, and this is not a group gather around frivolity, and it will be a good use of your time. I think that is already a mouthful. I would also want to add that at the end of this particular, once Professor Omisanjo comes back and gives us the other part and we take questions, please don't be in a hurry to go. There's going to be a group photograph. Just turn on your camera and give us a smile, and we'll take the picture, and that will be good. I would turn this back to the present child, and then we would continue the second part of this presentation. Thank you, and God bless you.
Thank you very much, Pastor Sukome, for that great introduction. And I must say very big thank you to Professor Omisanjo for honoring our invitation. He's very busy person, and so are a lot of our speakers. And they've all been doing this for free. So we really appreciate them that they've been taking time to impact and share knowledge with us. Before we go further, we're going to take a minute to remember a member of the Link family, a very active member of the Link family and a personal friend who passed away about 2 weeks ago and whose funeral is presently ongoing. And a dear friend. I think the picture is up, is it? Pastor Sukomi. Pastor Sukomi, is the picture up?
Yes, it's up.
Okay, thank you. Yes, so his name is Mr. Babatunde Folorunsho, December 8, 77 to July 15, 2026. Very active, a good man, someone who loved God, loved people. And I'll just like us to take 1 minute to remember him and to say a prayer for his family and loved ones who are grieving in this time, that God would comfort them. We are glad for the time we had with him. Though short, he lived a life of impact, and we that are still here hope to continue doing so. So help us, God. And his soul rest in peace. And with that, we will just return to our presentation right now. Over to you, Prof. Sorry, you're muted. Sorry.
Oh, yeah. You can hear me now. You can hear me?
Yes, sir, we can.
All right.
Yes,
Okay,
sir.
so fine. So I guess I have like 10, 15 minutes to just round off so that maybe about 10 minutes, right? So we talked about erectile dysfunction. So now the of course, men can also have ejaculatory disorders as they get older. Sometimes it's delay in ejaculation, sometimes it's an ejaculation, they just can't get that. Sometimes it's what is called the retrograde ejaculation. That can make the sex experience a little bit frustrating for men. And so again, it is important that we watch out for this and discuss with them as to what the options are. Because I'm pressed for time, we will quickly talk about prostate cancer, which is what I'd left to now.
We don't want you to rush, sir. If you need 15, please take 15 minutes. It's okay.
All right. Okay. Thank you. All right. So now I'll just go to prostate cancer. Now, the reason why we talk about prostate cancer in the elderly is because that is about of course, prostate cancer globally is rated as the second most common cancer in Nigeria. In most Black countries, it is the most common cancer in men, and it is basically a cancer of the elderly because commonly to occur after the age of 50. Of course, we've had men diagnosed with prostate cancer in their 40s, in their 30s. The youngest that we've ever treated, had documented, is a 20-something-year-old with prostate cancer. But very rarely will you see somebody with prostate cancer below the age of 40. It's typically something that occurs after the age of 50. And it is important we talk about prostate cancer because if you have a disease where recent figures will show, even in the UK, at least 10,000 men die annually from prostate cancer. In Nigeria, even with the dearth of the data that we have, we know tens of thousands of men die annually from prostate cancer. And what is more, in our own environment, most people come in late. And that is the sharp contrast between prostate cancer presentation in sub-Saharan Africa and say in the West, the bulk of people that will be diagnosed with prostate cancer in Europe, in North America, will present early. Whereas in sub-Saharan Africa, the bulk of people who present with prostate cancer will come in with advanced disease. And the importance is this: prostate cancer, unlike most other cancers, is curable. There are a number of cancers that, God forbid, anybody has those kind of things anywhere in the world. You're just looking at some time. But prostate cancer is curable. But there is a big if, and that is if picked on time. Unfortunately, most people do not pick it on time. The presentation in an environment is generally late, whereas abroad, most people come in early. And so, because it's a disease that tends to occur as people get older, beyond the age of 50, it is something we then for need to pay attention to. We know, again, back in the days, there was some research done in USAID in the 60s by Professors Song and Lawani, and what they said was that prostate cancer was an uncommon disease in Nigerian male, and I think they rated it as, was it the fifth or sixth most common cancer? Fast track to sometime in the 90s, Professor Gumbi, Professor Shitu did another study in the same institution, and prostate cancer had now become the most common cancer diagnosed in Nigerian men. Of course, what has changed in 30 years? Different theories. Some people think it's now, it's generally easier now to pick prostate cancer. Some people think it's a matter of lifestyle. Some people think, some mutation may have occurred. We don't know what has happened, but what we know is that prostate cancer is now the most common cancer that's diagnosed in Nigerian men. What are the risk factors? What are the things that predispose men to having prostate cancer? The three factors that are consistent, unfortunately, are what we call non-modifiable risk factors. So one is age. As a man gets older, above the age of 50. Two is race. We know it's a disease that is more common in blacks compared to Caucasians, compared to Asians. Every people group they have cases of prostate cancer, but it is a lot more common amongst blacks, whether you're a black person in Africa or you're a black American or wherever. It is more common in blacks. And the last risk factor that is consistent is the family history, especially a first-degree family history, like in a father, a brother, that sort of thing. Of course, it doesn't mean that once somebody's father has prostate cancer, the person automatically will have it. No, it doesn't translate to that. But what it means is somebody who has a first-degree family history of prostate cancer has a higher than average risk for that population of developing prostate cancer. All of these are things we cannot modify. Of course, there are now other factors that people talk about that have not been consistently shown. For example, exposure to, fatty diet, sedentary lifestyle, all those things and all that. People talk about so many other things. I'll come to sexual activity or lack of it, later. But the three most consistent factors that are known to predispose people to having prostate cancer are things we can modify: race, age, our family history. And that brings me to the point: it is important to know what is happening with our folks. Some of us come from a part of Nigeria where there is a saying that says, "Oh, whoever is gone is gone." I tell people, yes, whoever is gone is gone, but the genes, like something may connect the person who is gone and the person who is still around, and that's the same gene setup. So we need to know, because it's not enough to just say he died and we don't know what's causing it. It may have a history that may have some significance in assessing the risk that the people who are still living may have to developing some of these diseases. So it is very important we always look at it. We need to know that when people cross the age of 50, like I said earlier, for at least 50% of men who are above 50 will have some degree of prostate enlargement, albeit most of them being benign, but some of them will be cancerous. Now, the catch is, how do you now know which is benign, which is cancerous? Of course, sometimes by the time you make the diagnosis, it is obvious. Even somebody who is not a healthcare practitioner will know that this person is sick. He may not have the diagnosis, but the person knows the gentleman is sick. Nobody wants to be diagnosing cancer at that time. The best time we want to diagnose it is when it is early because that is when it gives one the chance of a cure. And that reminds me of, those days back then in secondary school when they used to share this Christian tract. There was a particular one of them that seemed to have an impression on me when they used to tell us that don't wait until 6 men carry you into the church before you go to the church. You know what that means, as in go to the church when you can walk in there and not when a funeral service is not being held for the person. So the thing about prostate cancer is the best thing is to pick it early, and that's why I'm spending some time on it rather than allowing it to announce itself. By that time, invariably it is late. What you're doing is just damage control. So what are the symptoms of prostate cancer? All those symptoms that we mentioned, from nocturia to urgency to all those lower urinary tract symptoms that can occur from changes in the bladder, changes in in the prostate, or from the benign prostate enlargement. Every single one of those symptoms can also occur in prostate cancer. And then, of course, because prostate cancer cells, like any other cancer cells, have the ability to move away from the prostate to other parts, people can now have what we call symptoms of metastasis, that is spread of cancer. So it can spread to the bone of the back and cause back pain. It can spread to the brain and cause seizures and cause headaches. Okay, so, but all of these are symptoms that people can have just from stress. Again, brings me back to the point that we should not trivialize symptoms, any symptom, any genital urinary symptom in the elderly. What is more, in the earliest stages of prostate cancer, the person can have absolutely no symptom at all. The only way you can pick that kind of prostate cancer would be if you screen for prostate cancer. And I will come back to that in a minute as a roundup so that people can ask as many questions as they have. So for prostate cancer, like I said, we can pick it, we can screen for it so that even before the person has symptoms, we deal with it. 2, we can pay attention to the earliest symptom that anybody complains of in the genitourinary system. And at least once the man is above 50, screen for prostate enlargement. And if there's an enlargement there, screen for possible prostate cancer. Or we just wait for the disease to announce itself and take it. And then you take it on the chin. Screening, I'll come back to. When people have prostate cancer, what are the treatment options? I said it before, prostate cancer is treatable, and indeed it is curable. In fact, when we diagnose prostate cancer in some men, when it is early, meaning it's still confined to the prostate, what we do now is to risk stratify them. That is, no 2 cases of early prostate cancer are the same. So we risk stratify them into what we call low risk early prostate cancer, intermediate risk early prostate cancer, high risk early prostate cancer. Those people that are deemed to have a low risk prostate cancer, we actually don't do any form of intervention. We don't do surgery. We don't do radiotherapy. You only monitor them. You do what is called active surveillance. What does that mean? You only monitor the patient regularly. Yes, you may need to repeat the PSA, repeat the prostate biopsy, repeat MRI, and all that. Why would you want to just monitor a patient who has cancer and not treat him? It is because we do know that there is a subset of men who have prostate cancer who have the non-aggressive type of prostate cancer. The kind of cancer that you say the patient dies with his cancer rather than from his cancer. You make the diagnosis and you come to that conclusion. You look at all the values. You come to that conclusion that the patient is more likely to die from something else with the cancer not bothering him at all than him dying from the cancer. Those sort of people, you don't need to put them through the rigors of all this treatment. But once you assess the patient as having an intermediate or a high risk early prostate or a high risk early prostate cancer, you must go ahead and treat. And prostate cancer is curable with surgery, it's curable with radiotherapy, it is curable with what we call HIFU, cryotherapy. There are all sorts of options available. If you're doing surgery, yes, the traditional open surgery is there, but the endoscopic, laparoscopic options are available. Of course, the in thing now is to do robotic assisted surgery, and even in Nigeria, we have 4 centers with robot available, and there are 1 or 2 centers I'm quite aware of who are still in the process of trying to acquire a robot. But what I tell people is this: of course, whether somebody is cured of the cancer or not is not dependent on whether it is robotic or laparoscopic or open. The advantage of one over the other is not in terms of oncological outcomes. No, not in terms of curing the patient or the person having a recurrence, is in terms of functional outcomes. So yes, you have cured the man of prostate cancer, but at what cost? He may have lost his erection, he may be incontinent and all that. Some of the newer methods may have an edge in terms of preserving, protecting the patient from some of those side effects and all that. But again, time will not permit me to go into the details of the treatment. But the thing to take from this is people need not be scared of this. If a diagnosis of prostate cancer is made, it gives one the opportunity of monitoring the patient if it's a low-risk disease, giving the patient the option of a curative treatment rather than waiting for it to announce itself in a bad way, by which time all you are doing is damage control. And what I tell people is, most doctors are comfortable in the job of a doctor. You don't want to be a doctor and you are a therapist and you are a priest, because what you're then doing is telling the patient, to prepare for the ultimate. Most doctors do not handle that too well. I know some people are better at handling it than others, but most people prefer that you come at a time when the doctor can be relevant than when, he's just doing damage control. So that takes me to, prostate cancer is treatable if picked on time. So that takes me to the issue of screening. And I will end with that because it is a controversial topic. It will sound simple that, it's simple. Why not go screen all men for prostate cancer, and then the ones that have prostate cancer, treat? That was what we used to do until some years ago. I remember the United States Foreign Service Task Force came to a meeting, the American Urological Association meeting, that was about 2012 in Atlanta, and they came up with this data showing that, it was not cost effective to be screening and all that. And the recommendation to the American government was that they should stop, regularly screening men regularly for prostate cancer. Of course, the AUA clearly put out a disclaimer that they were not part of that. But of course, these are independent bodies. Eventually, it came to be that people in the American government does not do this mass screening, regular screening of people for prostate cancer. That does not happen. Even in the UK, that no longer happens. In fact, if you check the UK National Screening Committee statement on prostate cancer as of this year, the only thing they recommend is what is called targeted screening. They do not recommend mass screening of men above 50 or 60 for prostate cancer. They only recommend targeted screening of men who have what we call BRCA2 gene and who have a family history of ovarian cancer. Of course, that's for women in their family who have ovarian cancer, breast cancer, or men who have prostate cancer. If that man now tests positive for BRCA2 gene, you then go on to do, screening for that man. But part of this is again, I said this is a controversial topic. If you look at part of what the people, so when you talk about screening, there is some argument for screening. There is argument against screening. The major argument for screening is that if you ask anybody the question, in absolute terms, does screening help protect men from dying from prostate cancer? The simple answer is yes. But it's not that. The question is at what cost? So what will have gone into saving those few men that you saved? Which is why the counter argument came in that, look, when you do this kind of mass screening of men across board blindly above the age of 50 or 60, you lose too much resources. You give too many men unnecessary treatment. So part of the data that's been thrown around is, if, for example, you screen about 1,000 men, okay, about 800 of them will be the ones that will need to have a biopsy, and you go on to confirm prostate cancer in them.
Am I the only one having him frozen?
No, you're not the only one.
You will end up saving 2 lives of men and overdiagnose like 20 men you are. But will have been like 12. You said I'm frozen? Hello?
Yes, sir. Briefly, you were.
Hello?
Yes.
You were, but it's okay now.
But you can hear me now.
Yes.
Okay, so I'll just let me quickly round up before I get frozen again. So I said, the argument for screening is that screening, yes, protects men from death from prostate cancer. But the counter argument against it is that you get to subject too many other men through unnecessary treatment that they would not have needed to protect those few men. And one of the common, the common data out there is averagely, you will have, by the time you screen 1,000 men and you get 100 of them, about 100 who have who you diagnose, who you go on to do prostate biopsy for, and some of them get the diagnosis of prostate cancer, you will save 2. For every 2 you save, you will have taken like 12 of them through a treatment they didn't need, and another about 20 through, some diagnosis that, they could have done without. So it then that's the question: is that judicious use of resources to save 2 men? When you look at it from a public health point of view, but if you flip that over, the question would be if you or somebody, if one, let's just say if any of us, or our father, uncle, or spouse, or anybody close to us happen to be one of those 2, will you still say yes, all those people who had the unnecessary treatment, let them have it, provided it will save the life of this person who may be me or the person next to me? Or will you say, well, I'm ready to give up my own life and not be saved and save these other 12, 20 people from unnecessary treatment? So in absolute terms, screening actually saves lives, but at what cost? And if you do so, but as of today, in North America, in UK, you don't do mass screening. It is discouraged. It's not recommended. The only recommendation by the UK National Screening Committee is for targeted screening of men with BRCA2 mutation. Having said that, I leave you with this. If you've been following the news, you will know, even in the UK, there is now a lot of what we call celebrity-driven push for prostate screening. And that is because you have top UK people, from politicians to technocrats, who have been diagnosed with prostate cancer in the past few years, and some of whom have come out to be advocating for men to go for prostate cancer screening. So as a roundup, yes, the data is there, depending on what you look at. Some will argue for screening, some will argue against screening. But on an individual basis, the advice is that once you have a man in your house, a black male that is above 50, you should encourage him to go for prostate cancer screening. Of course, what you now do with that information, we can have that discussion later. If you say, because for now, most of the international bodies do not recommend mass screening, you run the risk of missing out on the few men who could have been saved by screening. What is more, it is not as simple as they say. It is not a done deal. What do I mean by that? It is not as if the data is incontrovertibly in favor of lack of screening. Because as we speak, if you Google transform study, all right, that is a study that the UK government is committing tens of millions of pounds to. Professor Caroline Moore was at the SIU meeting in Glasgow that was November. She was again at the EAU meeting in London in March to talk about the transform study and what it's all about. And that's the UK government trying to do a number of randomized controlled trials to actually look at screening again. If the screening argument has been settled, that yes, we are very sure that there is no need for screening, I don't think the UK government will be committing tens of millions of dollars looking into screening. So there are arguments for screening for prostate cancer, there are arguments against it, but on an individual basis. Got a black man who's about 50 years, I would usually advise just go for screening, whatever it is people are talking about at the public health level. There are so many other things to talk about, but I think I'll just leave those ones on the question time, otherwise we'll be here forever. So once again, I thank you for having me, and thank you very much for listening. Have a good evening.
Thank you so much. Let's give a round of applause to Professor Omisanjo. Thank you so much, sir. I hope you know how to use the emoji buttons. Thank you so much. That's been amazing. Yes. So I hope people are getting ready with their questions. Of course, in GP land, where I am, We have to counsel patients when they request for prostate screening and also ask them why. So sometimes it's because they have a friend that has just been diagnosed with prostate cancer and it's a concern for them. And sometimes they just say they've heard about it in the news, they want to get screened. That's absolutely fine. But we also have to let them know that sometimes there can be false positives. There are other things that can raise the levels, and they need to be aware of that so that it is not unnecessarily anxiety inducing. However, having a strong family history is definitely a pointer for someone to have prostate cancer screening. I just want to ask that person that you said was diagnosed in his 20s, what was the reason behind that? Was that genetic? Was that someone you met personally? Prof, that's your question.
You want me to answer straight away?
Yes, please.
No, so he had obstructive. We couldn't do. We referred him for some genetic studies, but you know our limitations in our own environment. We really could not tell. But we felt strongly that it was probably genetic. But in terms of, we couldn't get that history from him. He denied, a family history and all that. But we do have. Just this last week, I still saw a 48-year-old man who had his own diagnosis out of the country at 47 and had the surgery. He had a family history. I have a family of 3 brothers, all of them. In fact, one was the one funding the care of another one when he then had to go and check his own. So you have sometimes some very strong, clinical leads to possible genetic predisposition, but we usually refer them for that. But these things are not easily available in Nigeria. And sometimes the patient just wants to be sorted out and is not following through with the genetic, screening testing.
Yeah. So what do you have to say to families that there's a lot of health conditions shrouded in secrecy? People don't want to do postmortems. They don't want to find out what caused something, but it could have like a knock-on effect years down the line.
I do not know. Maybe Pastor Sukomi may be able to help us more than me, and I'm serious about it. And I will tell you why. So, part of what I get involved in my center is kidney transplant, and we can do living donor. But again, because of the difficulties sometimes in sourcing donors, we're trying to move to a cadaveric, program. And part of the challenges we've had is, getting people, somebody that's brain dead, getting people to sign up for you to harvest their organs. You understand, because of all the things that I don't know how much of it is religious, how much of it is cultural, how much of it, which is why I said Pastor Sukomi may be better off at doing that. So sometimes the way we are, again, there is a Yoruba saying that, sometimes we just don't want to, even when you're doing well, they don't want you to tell people, because the thinking is when you're doing well, something, will just happen. Not to talk of when somebody is struggling anyway. I don't know how many people want to boldly, not all of us, to be like Professor Oliko here and Uncle who came out to say his brother died of HIV then. He was one of the first people to let us know. So part of it is culture, is just who we are. I don't think it's something a doctor can just change. We just need to know that we need to be more open about these things, okay? Again, politicians abroad, people who are in the public space, I just told you about this celebrity-driven push for prostate cancer because of the number of people who have come out to say they have prostate cancer in the UK. It may be changing a bit in Nigeria. I also know 1 or 2 people who have come out to say that in Nigeria. I know one of our top professors came out to say that. But it's like, is it a Nigerian thing, a Black people thing? We don't talk about these things, but we should all try to be a little bit more open. That information may not necessarily help us, but it may help somebody close to us. But the minimum we can do, at least we need to tell our children, tell our parents, the people that share these genes with us. That should be the barest minimum we should do. If you say you don't want to tell a friend, you don't want to tell somebody else, the people that share the same gene with us, I think we should be responsible. We should feel it like something we owe them. Then they need to know.
Thank you very much for sharing that. I'll just take some comments from the chats. 555, that's overall excellence. Thank you, Prof. Excellent delivery. Thank you for the wonderful teaching. Thank you, Prof. Olufunmilade Omisanjo. It was a great time of learning. Okay.
If I may quickly ask Prof a question.
Yes, please go ahead.
Okay, so I know thank you so very much, Professor Omisanjo. It was indeed a great time. When you were talking earlier, you were going to talk about it, but you said you would talk about this later on. And there's this controversy that you will hear people talk about, the association between sex or lack of it with prostate cancer and all of that, development of it. Can you please shed light on that and help the audience on it? Thank you, sir.
Okay, before
Thank
you
you very
take
much,
that
Prof.
question, I think you will take one more question. Chizoba, Dr. Chizoba, please, can we have your question? You can unmute yourself. Thank you.
Yeah, thank you so much, Prof. To be honest, the men's health is an area of medicine that I don't like, but you've made it so easy that, in fact, I want to see every man with lots, to be honest. I have some questions around the management of lower urinary tract symptoms. I don't know how much you, my question is, between voiding and storage symptoms, to be honest, I like voiding symptoms. Why? Because it's usually very straightforward. I'm more confident giving these patients tamsulosin, and because by the time they tell me I have pulse stream, I do their IPSS score, it's moderate, and we discuss it, and the patient is keen on starting the medication. I'm very happy to give them the tamsulosin. Now, my question is with the storage symptoms, like the frequency, urgency, nocturia, at times when they have these symptoms, and I ask them and I say, do you have any pressure? How do you, the patient will say, at times I feel like my bladder is not emptying completely. That puts me off. Why? Because one of the things that I worry about is retention in this patient. What do you think? I know when this is very distressing, very, very distressing, because I've had some patients who come to me and say, oh, doctor, I can't even go out because of how I feel with this. And at the end of the day, I will usually give them very low dose of zibutinib. But what do you think regarding giving these patients straightforward zibutinib and having to scan them for post-voidal residual? I don't know what you think about that. I have another question, but if you could answer this, please.
All right, thank you. Well, let's take those two questions and see how much time we still have.
Oh, okay, yeah. My other question is on incontinence. So for overflow incontinence, where they persistently like leak and stress and urge, for women, I'm very happy to send them to physiotherapist for pelvic floor exercise or incontinence team and all that. What do you think about sending a man? Maybe somebody who comes and say, when I dance, when I laugh, I leak. How do you feel about sending them for pelvic floor exercises? And for overflow incontinence, what will you advise? A referral to urology, or is there any other thing at all? Thank you.
Only you've asked 4 questions, Dr. Chizoba. Eh?
This is what I see in GP land every day, and at times my head, I just need some clarification on some things.
Thank you. Thank you for your questions. Yes, you can go ahead, sir.
Oh, thank you, Pastor Shumomi and Dr. Chizoba, for your excellent questions. So now, yes, the bit of association of sex, or more importantly, ejaculation with prostate cancer. Sorry, I didn't address that. Now, there are some studies that have shown that men with more frequent ejaculations tend to have a lower risk of developing prostate cancer. In fact, what's been common in the Nigerian space is the magic number has been 21, because that was what one of the studies quoted, that a man should aim to have at least 21 ejaculations in a month. But you need to know that there are other studies that did not corroborate, that finding. But the bottom line is this: what we always tell men is to just be as sexually active as they can in a responsible relationship, knowing that yes, regular ejaculations may be protective against prostate cancer. But what you cannot do is this: one, the man sets 21 as a target and feels that it's something he must attend to, because the truth is, sometimes as people get older, they are not able to achieve that. The interval between when men can have one ejaculation and another ejaculation can be as short as minutes in a very young man to days, in the much older man. And so putting trying to hit a target of 21 or whatever number it is people are quoting may be quite tricky for much elderly people. And in any case, you're looking at a 70-year-old man, say, if any ejaculation will be protective, it is ejaculations that is had much earlier. And the flip side is also that a man should not think once he's had 21 ejaculations in a month, he's therefore protected from having prostate cancer, because there can be other overriding factors like genes and other things and all that. So yes, there is a suggestion that more frequent men who have more frequent ejaculations may be relatively more protected from developing prostate cancer than men who have fewer ejaculations. And the theories about ejaculations help to flush out contaminants and all sorts of potentially toxic things out of the prostate and all that. But the important thing is that there can be overriding factors, and the most important thing is to check. So, that's that about that. Though I must say, some men are not happy when I say that, because I was at the church discussing this, and somebody was like, "I've just tried to remove one of the bargaining chips that some of them use to achieve some other things at their homes, because the man is aiming to achieve a target of 21." But seriously, people should just be as sexually active as they can. But still do the needful and check for any of these conditions. So management of lots, yes. So I agree with you. Sometimes the storage symptoms can be a little bit vexing. I mean, the voiding ones, you're able to quickly do something, and the patient, they tend to respond faster than the storage lots sometimes. So, but the way, because sometimes some of the patients will come with predominantly storage lots, sometimes they come with a mixture. When they have just voiding symptoms, it's straightforward. We just do tamsulosin. If the prostate size is more than 35-40, most people will advise that there's an advantage to adding an alpha reductase inhibitor like finasteride or dutasteride. If the prostate size is less than 30, most people will be okay with just you giving them an alpha blocker. If the patient has both voiding and storage lots, you can actually start with just concentrating on the voiding symptoms alone. What do I mean by that? Because sometimes when the patient have a mixture of that, the patient struggles to empty his bladder, he has some significant post-void, and it is actually the fact that perennially he has some urine volume in his bladder. That's part of why he's now passing urine frequently, because effective bladder volume is reduced. The urine in the bladder is always a continuous trigger for bladder contraction. So if you're able to deal with the voiding symptom, as in if you're able to give him something like tamsulosin or alpha reductase inhibitor, should he need it, the patient, once he's able to empty his bladder better, the storage symptoms get better, because you improve his effective bladder volume. You also reduce the irritation in the bladder, the risk of UTIs and all those things. So the preference would be to concentrate on the patient emptying his bladder at that time. Once a patient has some significant post-void urine, we usually will not want to give any of the anticholinergics, because, as that is one of the things that can tip a patient with significant post-void into retention. But however, there is also room for adding an anticholinergic to tamsulosin and 5-alpha reductase inhibitor in patients who have very disturbing storage lots, because some of them will tell you they wake up ridiculous things. Some people wake up 6, 7, 8 times, to wee. So while you are waiting for the tamsulosin and the ARI to help the patient empty bladder, you can start with some low dose, whether it's oxybutynin or sulfenacin or tolterodine, to reduce the storage lots. But the preference usually is to concentrate on helping the patient empty his bladder first and see how that improves the storage lots before you then say, oh, we then add something specifically for that. The other thing which we don't do enough as doctors is, helping them improve on their lifestyle. For patients who have nocturia, something as limiting nighttime fluid intake can help them. We talked about early dinner, and all that. Sometimes the patients may be able to identify some triggers: caffeine, alcohol. Some of them will smoke. Sometimes it's some spices, and all that. So some of these are behavioral things we can introduce that can help us avoid having to give, say, an anticholinergic in some of these patients. We also sometimes also do double voiding. We train them on double voiding. The patient voids 5-10 minutes after that, he goes to empty his bladder again, even without waiting for him to feel the urge. So that helps with dealing with the post void that he has. He's able to, because once you're able to empty the bladder better, reduce the post void, the storage symptoms usually will get better. And even if the patient now needs an anticholinergic, the dose you will use will be much less. And the lower the dose, the less the risk of those side effects you worry about. For the people who are overflow incontinence, absolutely, the emphasis has to be on dealing with that. So yes, the medication will be okay for some of them, but some of them, that would be an indication for you to do something surgical on the prostate, a TURP, HOLEP, or something. The only problem with overflow incontinence is, for some of them who've had it for a long time, not only do you now have to battle the bit of the obstruction, you now have to deal with a flaccid bladder, so that even when you relieve the obstruction with surgery, the patient has a thoroughfare quite all right, but the contraction of the detrusor muscle is so poor that very little urine comes out. But the surgery you have done is still not a useless surgery in that case. In that case, even without needing to give them an anticholinergic or anything for the overflow incontinence, once you relieve the obstruction, you are bolder to give an agent like betanicol that can help the patient's bladder contract better and empty his bladder. The reason why you will not give betanicol without relieving the obstruction is obvious. If you give betanicol without doing TURP or HOLEP in the patient who has a subsisting obstruction, is you're asking the patient's bladder to push against a closed door. So once there is urine retention or ultrasound or overflow incontinence, the emphasis, the priority will be on helping the patient empty his bladder completely, either by the use of tamsulosin, finasteride, dutasteride, if need be, the TURP, HOLEP, if need be, adding betanicol to help the bladder contract once you have evidence of a flaccid bladder. And if you must give, say, an anticholinergic for a patient who still has an ongoing retention because of the disturbing storage symptoms, yes, you can give low dose oxybutynin. But the other thing you can do is you can go to a B3 agonist like mirabegron. I know it's not something that is as commonly used in the UK as it should be. The advantage of using B3 agonists like mirabegron is you can achieve the same thing you will achieve with oxybutynin with very minimal risk of tipping the patient into retention. So that would be the way to approach it. Do we do pelvic exercise? Yes, we always advise it, even in men who have, whether it's stress incontinence or urge incontinence, as a complementary step to some of these things that I've answered. Dr. Ayedo is already looking at me, but I'll take any one of you if you have any additional clarification on this.
Thank you very much, sir. I was beginning to get aware that a lot of people might not understand what you're saying, apart from the medics among us, but it's fine. You've said a lot that a lot of people already understand, so that's amazing. Thank you so much. So before you go, there's one question. In Nigeria, it's called Magu. I don't know what the medical name is. What is it?
Well, I think the doctor is asked to be. I defer that one to Dr. Sukomi. But basically, what we know it to be is so a woman has basically an extramarital affair, and the man that is the partner then dies. And usually there is a taboo that is put to the voodoo, because it's usually, there is no science to it, it is voodoo. So the thing is always that the man must not, they will say whether he must not drink water or he must not do something, and once he does that, then something happens. if you ask me, there is absolutely no science to it. Can a man die following sexual intercourse? Of course. I did say, I mean, men have cardiac issues. Like I did say that sometimes I've treated people in their 80s for erectile dysfunction. The precaution you take in the more elderly patients that you treat for erectile dysfunction is to be sure they have a good heart. One of the things time did not permit me to say is we say when we discuss erection that a man's erection is a window to his heart. What do we mean by that? There is an association between erectile dysfunction and cardiovascular disorders in middle-aged men. So if a man in middle age comes complaining of erectile dysfunction, one of the things we advise, whether it's the GP, the family primary care physician, or the urologist to screen for is cardiovascular illnesses, because men who have erectile dysfunction have a higher than average risk of having cardiovascular disorders. So if a man has cardiovascular disorder and you do not know, and you give him something to improve his erection, the man may die in the act. And of course, it may just be because maybe the man was going to do something, he went and did it somewhere else. He just died from, the exhaustion of this act, and not because he was any mago. Pastor Osunkanmi may have another dimension to it. That's the much I know about that.
Thank you very much, sir. Thank you very much, sir. I don't know whether anybody has any other questions or comments as the last one before we let Prof. Omisanjo take a bow. Anybody? I also know some people might develop a very severe thunderclap headache that might land them in hospital if they burst a vessel in the brain in the act of intercourse as well. So just decided to add that in just for those that don't know.
Yeah, I think I know Prof kept saying that maybe I would say something.
Okay, so you decided to say something. Please
But
go
no,
ahead.
I just wanted to say that the Yorubas will say that it is in the mouth of the elders that the kola nut is ripe. So you have said it, sir, and I think we can take our cue from there and move on.
Thank you very much. So, round of applause for Prof. Omisanjo. Thank you so much, sir. We appreciate your time. We appreciate your efforts. God bless you. Thank you so much. Warm regards to my sister and my children.
Thank you.
Okay, so we've come to the end of episode 8 of our Aging and Elderly series. I hope you've been enjoying it immensely. I have. It's been an amazing time. Next week, we are going to be discussing urogenital concerns in aging women. And that's going to be a very interesting one to watch out for. So please stay tuned. Invite your friends and family, all the women in your life and those who love them, to attend that session. It would be another time of learning and insights. Good evening, sir. Would you like to say something? You're muted, sir. You can unmute yourself.
I'd like to thank Pastor Sukomi for bringing me into this forum. It's a very useful forum.
Thank you,
and
sir.
I want to thank the presenter. It was a wonderful presentation, very classical. And there are questions I would have loved to ask. Now that we are closing, I will talk to Pastor Sukomi tomorrow in the church. Maybe he could link me up with the Prof, so we can talk at that level. Thank you very much for this beautiful opportunity.
All right,
God
sir.
bless
Thank
our every effort. Thank you very much, ma.
Yes, sir. Thank you very much, sir.
You're welcome.
Okay, so as I said, we're looking forward to our next episode, and it's actually 13 sessions we're going to have, because we've added on an extra session in which we are going to be talking about oral health in the aging, skin conditions in the aging, and eye health in the aging. So that's going to be wonderful. That's going to be our very last session, the last Saturday in August. And for those that are in the house, next week is the last Friday in July. So we're going to have a prayer meeting by 9 p.m. and then we're going to have our usual session on Saturday by 5 o'clock. And so with that, Dr. Ijoma, are you ready for our photo? Let me know if you're ready for our photo so we can take it.
Yes, I am. Yes, I am.
Okay, yes. Please kindly show us your wonderful faces so we can take a group photograph and send it to you. So if you're able to show us your face, we're going to take a group photograph. And let us know when you've taken it, Sister AJ. Thank you.
All right.
I'm so glad to see many people's faces today. It's amazing to see your faces. Thank you for putting on your cameras.
Yes, I'm done. Thank you.
Thank you very much, Dr. AJ. Okay, and so we end with our motto. If you can just unmute yourself and we say our motto after me. I live in love.
I live in love.
I stay in peace.
I stay.
I shine my light.
I shine my light.
I use my power.
I use my power.
So help me God.
So help me God.
Amen. Thank you very much. Big thank you to those that joined on the YouTube channel. If you haven't subscribed, please subscribe and please check out all our previous episodes and series. God bless you and see you next week.
Amen.
Thank you, Prof. Ayedo. Thank you, Jesus is Lord. Thank you, Dr. Olaiwola. Thank you, Mommy Lara. Thank you, Mommy Bafunke. Thank you, Grandma Shorumo. Thank you, Mr. Benga Ajayi. Thank you, Dr. Chizoba. Thank you, Techno Spark. Thank you, Mr. Asan Kumadin. Thank you, Dr. Ojediro. Thank you, Sister Enito. Thank you, Mr. Punsho Fash. Thank you, Mommy Omowale. Thank you, Mr. Oshokbale. Thank you, Apostle Francis. Thank you, Sister Olanike. Thank you, Sister Ori. Good to see you. Thank you, Mr. or Mrs. Ayoride. I don't know whether that's a man or a woman. Thank you, Sir Olatunji. I can see you are elderly. Thank you, Sir Oteshile. Thank you, Uncle Tunji. Thank you, Kevin Papi. And thank you again, Prof. Omisanjo. God bless you, sir.
Thank you.
Bye, everybody.
Bye.
Bye.